So it's a common occurrence in patients who have underlying cancer. And importantly, one of the key messages of this talk is that when AKI occurs in patients who have cancer, it's associated with a negative impact across the care continuum. It impacts chemotherapeutic regimens. It changes the dosing requirements for many drugs and actually limits some of the chemotherapeutic regimens that patients can achieve. It's associated with longer length of stay, lower cancer remission rates, especially for hematological malignancies, and a much higher mortality. And there's clearly differences in etiologies, preventions, therapies between the solid and hematological malignancies, and I'm going to touch on that as well. So there's not much in the world of epidemiology in the cancer literature that really focuses just on acute kidney injury. This is one Danish study that looked at about 1.2 million people who had cancer and looked at the acute kidney incidence. The take-home is that acute kidney injury in these patients is quite common. Well, the one-year risk of a patient with an underlying malignancy having acute kidney injury in the study was nearly 18%, as defined by a greater than 50% rise in serum creatinine. Over 5 years, that risk nearly approached 30%. And that risk was highest in patients who had underlying renal cell cancers, about 40%, liver cancers, and myeloma. And you can see here the gradation between risk, injury, and failure, with failure obviously being the slowest, about less than 10% over a 5-year period. When you look at other studies in the literature, this is a cancer ICU looking at 288 patients, grading the change in serum creatinine, the percentage of patients that had that, and the mortality rate. You can see there's a very clear gradation in mortality that occurs as patients have more severe renal failure. So that those patients who required hemodialysis had mortality rates that approached 90%, a very, very high incidence. And we'll see as I drill down to some of the other malignancies that especially for some patients, it approaches nearly 100% when it requires dialysis therapies. Now, when you looked at the etiologies that occur in solid organ cancers, the etiologies generally are similar to the general population with a slight overrepresentation of obstructive causes, especially for prostate, ovarian, and cervical cancers, nephrotoxicities, which I'm going to touch on towards the end of the talk, sepsis-associated, especially in neutropenic patients, hypercalcemia-associated acute kidney injury, and tumor lysis syndrome, which I'm going to discuss in some depth subsequently. In hematological malignancies, the incidence vary as well, myeloma being the most common, about 31%, followed by patients with leukemia and lymphoma. There's good data in hematological malignancies that when patients do suffer acute kidney injury, it clearly limits the chemotherapeutic regimens that oncologists can provide, and that's associated with lower remission rates, increased relapse rates, increases in the likelihood of having refractory diseases. And I think an important take-home point is that those patients with hematological malignancies who develop acute kidney injury and have dependence on dialysis have a particularly poor prognosis, with nearly 90% of those patients passing away within about 6 months after the discharge from the intensive care unit. Now, I want to touch on some of the etiologies in a little more depth, and this starting with pre-renal azotemia. It's clearly the most common causes of acute kidney injury in all cancer types. If you look at hematological cancers, solid malignancies, and stem cell transplant. Certainly, there's poor intake across all malignancies owing to the chemotherapy-induced anorexia, emesis, and diarrhea. There's sepsis, which is common due to neutropenia with renal hypoperfusion across the care continuum. There's coexistent cirrhosis or heart failure, hypercalcemia, and then medications associated with pre-renal azotemia. Unique to the stem cell transplant is a cytokine release syndrome that can occur with engraftment that's associated with third spacing of fluids and also can be associated with a reversible pre-renal acute kidney injury. I want to touch on some selected etiologies in a little bit more depth and give you maybe an update on some of these, including tumor lysis syndrome, infiltration of the tumor into the kidneys, a little bit about obstructive thrombotic microangiopathies, renal cell cancers, and post-nephrectomy acute kidney injury, and touch on nephrotoxins, and then finally just close with some points about stem cell transplants that I think are relevant. So first, the tumor lysis syndrome, a relatively common occurrence of acute kidney injury. It's defined by the Cairo-Bishop definition that includes hyperuricemia, hyperkalemia, hyperphosphatemia, hypocalcemia, most importantly, a serum creatinine defined as 1.5 times the upper limit of normal. The risk factors for tumor lysis syndrome include acute lymphoblastic and leukemias, especially when the white cell count is above 100,000, myeloid leukemias when the white cell count is above 50,000, and fast-growing tumors like Burkitt's lymphomas or large B-cell lymphomas. Generally, patients with tumor lysis syndrome have very large tumor burdens. They can be predicted by having high LDH values, and they tend to be very chemotherapy responsive. In fact, that's true for all chemotherapy regimens, even including the biologics. Most patients will have extensive bone marrow involvement as well, and there are cases where it can occur spontaneously or even after inadvertent therapy. We recently saw a patient who was getting some steroids for a dental procedure. Unbeknownst to the dentist, actually had lymphoma and presented with acute renal failure from tumor lysis syndrome just on the basis of that. The pathophysiology is basically due to the breakdown of nucleotides that are released by these tumor cells. Those nucleotides are processed to xanthine, and then by xanthine oxidase to uric acid, which is the primary motivator in terms of acute kidney injury. Uric acid is poorly soluble and precipitates in the kidneys. I'll show you that in a second. But the importance of uric acid, again, highlighted here. And remember that most animals actually have urate oxidase, which is absent in humans, which can metabolize uric acid to allantoin, which is a very soluble chemical that's easily excreted in the urine. Humans don't have that enzyme, and thus uric acid is made in excess quantities, precipitates in the tubules, and leads to acute kidney injury. I'm going to come back to treatment in a second, but just to point out here that allopurinol blocks xanthine oxidase, thus decreasing uric acid production, and the enzyme rasburicase, which is a urate oxidase, actually takes uric acid to allantoin and can be given for treatment of this. The role of uric acid, again, is primary. It turns crystals in the tubules. Then acid urine favors urate, which makes it more soluble, and moves it to the uric acid from urate form. And there's also tubular glomerular feedback that occurs as these tubules become full of these uric acid crystals that reduces renal blood flow and GFR. The crystals are also very pro-inflammatory, and they induce a cytokine release in the tubules, leading to local inflammation as well. Now, in terms of treatment, just briefly, just to give you a little bit of an update, urine alkalinization had been promoted as a good thing to do. The idea here was that you moved uric acid to urate, which is more soluble in the tubules. However, when you look at studies that look at urine alkalinization, there are several problems that actually make it not a good idea. First of all, it increases the risk of calcium precipitation and calcium phosphate precipitation both extrarenally and in the kidneys. It reduces ionized calcium, which can be low in these patients to start with. And perhaps most importantly, at higher pHs, xanthine and hypoxanthine, which are metabolites that are upstream of uric acid, have lower solubility at the higher pHs. And this risks having another form of tumor lysis syndrome where you have xanthine crystal uropathy, especially if patients are getting allopurinol, which will increase the concentration of the upstream xanthines. So urine alkalinization is no longer recommended. What is recommended is allopurinol. Again, inhibits the xanthine oxidase. It reduces uric acid synthesis, but doesn't directly reduce uric acid levels. So it's good for a prophylactic agent, but not for a treatment agent. The treatment agent really is rasburicase. It's a recombinant urate oxidase. It's indicated as a single-course therapy for patients who have very high plasmic uric acid levels or patients who are at very high risk of tumor lysis syndrome. It's important that it's really a single-use agent because about 20% of the patients will develop antibodies to rasburicase and leads to a risk of anaphylaxis. It's also contraindicated in patients with G6P deficiency because of its risk of causing methemoglobinemia. Here's some data with rasburicase showing that here's a patient untreated with the uric acid levels, showing levels between 6 and 7. With rasburicase is given, those levels fall very low very quickly within a matter of hours and remain low for several days. So for prophylaxis and treatment of tumor lysis syndrome, just quickly, IV fluids, alkalinization is not recommended, allopurinol is prophylaxis, and rasburicase for treatment of patients at high risk, and also treatment the other associated electrolyte abnormalities, and dialysis is indicated in a small subset of patients. With the initiation of rasburicase, this has become much, much less common Obstructive uropathy, just a couple of points here, obviously due to massive tumor burden associated with usually prostate, cervical, or ovarian cancers, rarely due to retroperitoneal fibrosis as a paraneoplastic syndrome, and diagnosis with ultrasound and treatment with decompression with stents or nephrostomy tubes, with usually some relief after following with chemotherapy or radiotherapy. Another cause that is relatively rare, but one that we don't want to miss, is tumor infiltration. The tumors, actually, the kidney is the most common site for extrareticular and extrahematopoietic infiltration by leukemias, lymphomas. It occurs in about 60% of patients. However, renal failure is usually quite uncommon in these patients, and patients will present usually with flank pain, hematuria, abdominal distension. They'll have hypertension and bilateral renal enlargement on ultrasound. Again, we think AKI is relatively uncommon from case series, and it's probably due from tumor cell compression of the tubules and the interstitium, leading to disruption of the renal microvasculature. There's really rapid improvement in renal function when patients are given appropriate chemotherapy. It can improve within a few days, with regression of the renal masses that occur as well very, very quickly. This is just a biopsy specimen of a patient we saw, where you see multiple islands throughout the kidney infiltrated by these leukemic cells, and you can see significant compression of the tubules and microvasculature here. Thrombotic microangiopathy has now been recognized recently as an increasing incidence of acute kidney injury, and this is largely due to chemotherapeutic regimens, especially drugs like gemcitabine for pancreatic cancer, and most commonly with these anti-angiogenesis therapies like bezacivimab. Thrombotic microangiopathy can also occur in patients who are getting stem cell transplants and can coexist with patients who are getting graft versus host disease as well as radiation nephropathy. There are no really good controlled trials for treating a thrombotic angiopathy, but case series certainly point out that things like plasmapheresis, changing therapies from cyclosporin-based graft versus host prophylaxis regimens to tacrolimus, and the use of rituximab in cases can be beneficial. Now, I just want to touch on really, I think, an important topic, which is the incidence of acute kidney injury post-nephrectomy. It's usually in patients undergoing renal cell cancer surgeries. In one study, 519 patients undergoing a radical nephrectomy with a GFR greater than 60 preoperatively, about a third of those patients developed some form of acute kidney injury, and that's associated with about a 5% increase in CKD risk a year postoperatively. Partial nephrectomy, which is now moving to be the treatment of choice in nephron-sparing surgery, is associated with about a third less of acute kidney injury. And I think most urological surgeons now have really keyed into this. There's a recent position paper by ASCO, the American Society of Clinical Oncology, that now it really moves the field, especially for small renal masses, to partial nephrectomies and nephron-sparing surgeries, likely due to really an awareness that, especially in patients with CKD, that the risk of acute kidney injury and worsening CKD is relatively high in this subgroup of patients. Lastly, I just want to touch on some chemotherapeutic issues and some recent data about some new agents that I think is important to recognize. Here's just a cartoon of the tubule showing that chemotherapy-induced drug injury can occur multiple sites across the nephron. There's drugs that affect the vasculature, especially the anti-angiogenesis therapies that target the vascular endothelial growth factor, drugs like gemcitabine. These typically present with thrombotic microangiopathies. There are drugs that affect the glomerulus, like interferon therapy, pamidronate, that can lead to proteinuria, nephrotic syndrome, and glomerulonephritis. Numerous drugs affect the proximal tubule, causing acute tubular necrosis, cisplatin and ifosfamide I'll touch on. There are drugs that also affect the interstitium, nitrosoureas, and most importantly, a new class of drugs called the checkpoint inhibitors. These drugs are really very powerful immune modulating drugs that are used now very effectively for the treatment of melanoma, as well as breast cancer and colon cancer. These drugs are associated with a very high incidence of acute interstitial nephritis. And really, these are important to recognize because this is a very steroid-responsive form of acute interstitial nephritis and acute kidney injury that gets better quite quickly with steroids. Finally, there's drugs that affect the distal tubule. There's cetuximab, used largely for colon cancer, that leads to magnesium wasting syndrome, and drugs that affect the collecting duct by crystallization, such as methotrexate. I just want to drill down on 3 drugs, cisplatin, ifosfamide, and methotrexate, and just give you an update on some new data. Also remember that these patients, cancer patients, are receiving multiple imaging studies, often with contrast throughout their course. It is really not well studied, the impact of these multiple hits of contrast agents, but certainly it's believed that this contributes to the large incidence of acute kidney injury as well as CKD in these patients. So in terms of ATN, a long list of drugs that can do this, many cancer drugs, and this list is evolving pretty much weekly. But just talking about the most common ones are cisplatin. It's a platinum compound that's very effective, especially in epithelial cell cancers, squamous cell cancers. And its major nephrotoxicity effect is, on the kidneys, followed by ototoxicity. These are dose-related toxicities. It leads to cellular apoptosis and necrosis, but the nephrotoxic manifestations that affect the proximal tubule can be quite wide-ranging. They include tubulopathy with a Fanconi syndrome, with pretty profound salt wasting, as well as magnesium wasting and nephrogenic diabetes insipidus, and also as well as acute kidney injury. And the acute kidney injury, the pathogenesis I'll show you in a second, but is really multifactorial that includes both ischemic and direct nephrotoxic effects. The nephrotoxicity is often, but not 100% reversible, and patients can be left with both CKD and predominantly long-standing tubulopathies with electrolyte wasting that can continue for many years. In terms of pathogenesis, cisplatin is taken up by this OCT2 protein, this organic cation transporter. It's taken into the renal epithelial cell, where it can cause significant cellular damage and cell death. But cisplatin also causes vascular injury directly, leading to ischemia of the tubules, as well as activating TNF-alpha, leading to inflammation. So cisplatin really affects multiple pathways, leading to kidney tubular damage, decreased GFR, and manifesting as acute kidney injury. Prevention is really multifold. Forced diuresis. There are several antioxidant agents that can be used with a variable benefit. But usually the best preventative thing is to try to use other platinum compounds that are less nephrotoxic than cisplatin, that are not taken up by this organic cation transporter. And these are much less toxic agents. Ifosfamide is also probably the other prominent tubular toxin. It's an alkyl-aging agent used for certain cancers. Again, its major effect is nephrotoxicity, and it's really due to this toxic metabolite called chloroacetaldehyde. The nephrotoxic manifestations are similar to cisplatin with tubulopathies and proximal tubular injury, followed by acute kidney injury. Again, the acute kidney injury can often be reversible if caught early and the drug stopped, but can be permanent as well. The nephrotoxicity is very similar, again, to cisplatin. The drug is taken up by this organic cation transporter. It's metabolized to chloroacetaldehyde, which is significantly toxic, and that leads to tubular injury and cell death. Again, prevention is really with some antioxidant therapies like Mesna, dose reduction, and thinking about drugs that potentially block this organic cation transporter like cimetidine. It's unclear how effective that regimen really may be. Long-term, again, patients will have persistent tubulopathies in about 10%, and isolated renal phosphate wasting occurs in about 20% of patients that can continue lifelong. Finally, I just want to touch on methotrexate. This is, I think, an evolving area because methotrexate is really now one of the key chemotherapeutic agents in conditioning patients for stem cell transplant across the world. Methotrexate can lead to both an acute and chronic nephrotoxicity that's due predominantly to precipitation and deposition of the drug in the distal tubule. And that risk of precipitation increases in patients when they have low tubular flow rates, when they're dehydrated and have volume depletion, and when they have low baseline GFRs, or when you're using very high doses of the drugs, such as in these myeloablative pathways. Methotrexate is predominantly, if not all, cleared by the kidney, and when patients have an acidic pH or low GFRs, that leads to precipitation. Urinary alkalinization does increase the solubility of methotrexate and should be used in these high-dosage regimens. The acute kidney injury that's often seen is non-oliguric. It's often associated with very high serum drug levels and metabolite levels. And the key issue here is when the patient goes into acute kidney injury from methotrexate, the methotrexate levels rise very quickly, and that can lead to severe, if not permanent, bone marrow suppression, as well as neurotoxicity. And this leads to really a pathway that's circular in that the drug levels continue to rise, the nephrotoxicity worsens, and the downstream effects of methotrexate in terms of bone marrow suppression get worse. The way this is treated is with glucarbidase. This is a drug that metabolizes methotrexate to a soluble, non-toxic intermediate that can be rapidly excreted by the kidney. Or if acute kidney injury does manifest, patients will respond to high-flux hemodialysis with removal of methotrexate as well as treatment of their acute kidney injury. Finally, just to touch on some things about hematopoietic stem cell transplant. Just as a reminder, there's really several different forms. There's autologous bone marrow transplants, which can be done by peripheral blood. There's allogeneic bone marrow transplants, where it can be used cord blood, peripheral stem cells, or bone marrow. And with these, there's either myeloablative, where the bone marrow of the host is completely ablated, or non-myeloablative regimens. And there's three basic steps that occur during a stem cell transplant. There's intensive conditioning, there's donor cell infusion to rescue the patient from the myeloablation, and then there's post-graft immunosuppression to prevent graft versus host disease. Here is just a list in terms of the risk for acute kidney injury. The risk for acute kidney injury is highest in those patients who are getting allogeneic, either myeloablative or non-myeloablative pathways. And this is really in large part associated with the risk for acute graft versus host disease and the need for post-transplant immunosuppression, usually with a calcineurin inhibitor. The overall incidence of acute kidney injury in stem cell transplant patients ranges, depending upon the center and their experience, between 30 and 70%, very wide range. Acute kidney injury requiring renal replacement therapy occurs in anywhere from 1 to 19% of patients. That risk is greatest in the first 100 days after the transplant. And unfortunately, the risk of mortality in those patients who are getting a myeloablative allogeneic transplant who require renal replacement therapy approaches 100%. One of the key issues for acute kidney injury, which is a relatively rare but needs to be recognized by the kidney specialists, is veno-occlusive disease or sinusoidal obstructive syndrome. This is a unique pathogenesis associated with hematopoietic stem cell transplants. It's associated with several regimens that include busulfan, cyclophosphamide, and total body irradiation. And what's seen for very unclear reasons is that the liver develops very severe sinusoidal obstruction, portal hypertension, and microvascular portal systemic shunting. The clinical presentation is very similar, if not almost identical, to the hepatorenal syndrome. And the differential diagnosis for AKI includes hepatorenal syndrome, pignate nephropathy because the patients have bilirubin levels that are very high, or a thrombotic microangiopathy. Treatment is really focuses on hopefully prevention. There's several different regimens depending upon the center that uses drugs that solubilize bilirubin, drugs that are used as antioxidants, and low-dose heparin to prevent anticoagulation. These drugs have various efficacy rates, none of which are completely 100%. The nephrologist's role tends to be supportive after acute kidney occurs, but it's really important to recognize this and be able to differentiate this from the multiple different causes of acute kidney injury that occur post-stem cell transplant. So just to summarize, acute kidney injury is common in patients with cancer. It has unique features, which I've tried to cover very quickly in terms of unique pathogenesis and etiologies. Those require specific diagnostic and therapeutic regimens. Medications are a very common cause of acute kidney injury, need to be recognized, and one of the things that really is important in this field is really to use biopsies in diagnosing acute kidney injury because the differential can be quite wide. One thing I didn't touch on is that decision-making when acute kidney injury occurs in patients who are critically ill and with cancer is very complex. It's best done within a multidisciplinary model with the patient and the family input.